We're going to go ahead and get started again with our next speaker. Our next, who's John Hornick. John was director of the research at Advocates for Human Potential from 1997 to 2011, and he is now working as a private consultant. Since 2007, he has been a member of the Department of Mental Health Western Citizens Advisory Board and is currently its president. And as Kristen mentioned, he was a member of the technical expert panel advising CMHS on the development of the state self-assessment tool. He has a full career worth of fabulous experience in services research, evaluation, and planning for mental health and substance abuse. And he's going to talk to us more today about using data to plan for community integration, which will dovetail nicely from Kristen's talk. And we're honored to have him here. Thank you for joining us.
Good afternoon. I want to thank Chuck and Deb for inviting me, having confidence that I'd have something interesting to say. I really do want this to be interactive, and so as I go through my slides, don't feel any hesitancy to say, that makes no sense to me, or, gee, I wish I'd thought of that, or add a question or some other kind of comment. I will move more slowly, probably than Kristen, probably because I'm almost twice her age. Okay, so this is also about community integration. And this talk has its genesis partly over a long career thinking about how to use data to support whatever it is state mental health authorities want to do, and partly in my experience with the project that Kristen was describing, and one thing that came out of it. Since early this summer, I've been doing some consultation with the Adult Mental Health Division of the state of Minnesota. We are providing some larger technical assistance to that division, specifically to Cynthia Godin, who's the director of the division. And Cynthia asked me to look at a particular set of problems, which probably everybody else has too, that are characteristic of their system. Basically, there are people backing up. She was particularly focused on their large single-state civil hospital, where there are many people waiting on what they call non-acute days, that is days when they no longer be in the hospital, but the hospital has been unsuccessful in placing them for any number of reasons. To some extent, we believe the same is probably true for local community inpatient units. There's also a few local state inpatient units in Minnesota. There are stories about individuals being inappropriately turned away, certainly from the large civil hospital and also from local hospitals. People believe there may be there's certainly a shortage of housing, no question about that. The state also has a step-down program called intensive residential treatment, and some concern about whether that program is large enough, and that's one of the causes of all the backup. I'll come back to that. Here are problems about emergency and crisis programs being backed up, or people not being able to get access to those, or to various kinds of outpatient. My colleague Jennifer Erf and I spent 3 days talking to various groups in St. Paul about the problems they experience, and people say, well, someone gets hospitalized, when really all they needed to do was to be able to see a psychiatrist and get a medication prescription refilled, or see an outpatient therapist, and the system's blocked up, they can't get in, so they wind up in a hospital. So I could go on, but the key thing is that movement through the system doesn't work. And what Cynthia asked is, can we develop a flow model? Can we develop a model of movement through the system that would help us understand where things are getting stuck and might point us in the direction of what we could do? So part of what I'm going to talk about is how I've been working to try to answer that question. But I'm also going to talk about the larger role of data. Let's see. I'm going to talk about these issues. How to think about data, which is the way I think about it. How to use data to identify problems. I'm going to acknowledge that data alone won't solve problems. It's good to have something to point to identify. And one of the key problems, of course, when you talk about community integration is housing, and data alone can't create housing. On the other hand, there may be ways in which it can help. Okay. First and foremost is this idea that you need to analyze data from the perspective of the entire public mental health system. Now, most of us join state mental health authorities, and kind of given that you're in that context, there is a tendency to think that the state mental health authority is the public mental health system. In my view, it's not. The public mental health system, my definition, is any mental health services that is operated, funded, or licensed by the state, not just the state mental health authority. For example, in many states, local community hospital inpatient units are licensed by the state health authority. Their correctional system, both state corrections and local corrections, jails, have mental health programs that they run, sometimes with the assistance of a state mental health authority, sometimes not. Some of those can be pretty big. I don't have to probably repeat to this audience the fact that people talk about the Los Angeles County Jail as the largest inpatient hospital in the country. So basically, you've got a lot of mental health services being delivered outside the purview of the state mental health authority. And the truth is, probably more than half of all services that are mental health are outside the purview of the state mental health authority, although they are publicly funded. And so if you don't pay attention to them, you really can't understand what's happening to people inside the state mental health authority. Okay. Where does the state mental health authority fit? 50 years ago, basically the job of the state mental health authority was to run state hospitals. That's what they did. And they've been doing it for 50 to 100 years before that. And so that's the way everybody thought about the role of the state mental health authority. Then you had some outpatient services that the state operated, depending upon the state. New York was a state that started to develop state outpatient services that were based in its institutions. Other states also went pretty quickly to state contracted programs. Part of that is because of the development of the Community Mental Health Centers program, the federal program in the 1960s. Later you had other things like the federal block grant, which really came out of the CMHC program. So part of what's happening is, even from the point of view of the state mental health authority, you have changes in programming and also changes in how things are financing just with state appropriation. But then there are a lot of other sources for other state mental health authority, as I mentioned briefly earlier in response to an earlier conversation. In most states, state Medicaid authorities pay for at least 50% of all services. That can include the services in state hospitals. Thank God for disproportionate share, particularly, but also many other places, including community hospitals, a variety of community programs. And that's been growing since the mid-60s, when the Medicaid program came into being. The state health authority, as I said, licenses local inpatient programs, They license nursing home programs, which have a significant proportion of individuals with serious mental illness. The State Housing Agency has authority over any number of HUD programs that are in the state, and a significant proportion of those programs serve people whom we tend to label as seriously and persistently mentally ill. It's true for the State Rehab Authority, the State Education, and even Social Security. In many states, eligibility for SSI is turned over by the Social Security Administration to a state agency that actually decides whether individuals are eligible for SSI or not by reason of mental illness. So again, you've got another state agency in a role, even though it's federal money, that is part of what's happening in your system that's really important. I remember Howard Goldman saying, a couple of years into the Reagan administration in 1980, for those of you who were born a bit before that and some might be familiar with it, that Reagan took the Community Mental Health Centers Act and cut a lot of money out of it, and the community mental health providers were pretty angry, appropriately, when they turned it into the block grant, and states had the authority to distribute either the same way or a different way, albeit with less money. But he said the biggest impact of the Reagan administration on people with mental illness, serious mental illness, was tossing thousands of people off the rolls of supplemental, of SSI, supplemental security. Thousands of people. And nobody was really protesting about that. So there are all of these sources of funding that are really important to the people that you all serve. 25 years ago now, roughly, the Congress passed a law which was then described as PL 99-660. It was a renewal of the block grant law, which keeps changing, but this one aspect of it hasn't changed. It was something that the advocates pushed the Congress to do. And basically it said that state mental health authorities, or states I should say, were responsible for the individuals in the state who are seriously and persistently mentally ill, as well as seriously emotionally disturbed, and for assuring that they get the services they need. And that was the beginning of state planning councils. State planning councils, as I'm sure all of you know, are mandated not only to include the state mental health authority, but corrections, probation, parole, health, housing, I can't remember, but there's a list of at least 8 or 9, 10 other state authorities that are intended to participate because they control programs that are needed for people who are being served in your systems. So, from my point of view, the premise is state mental health authorities are basically now conveners of all state agencies. There was also some emphasis on this in the most recent state transformation grants that CMHS has promoted. The earlier ones, which were a lot more money and more years than the current ones. But this is critical. State mental health authorities really don't have authority over much more than their appropriations. But for there to be state mental health authorities, somebody has to pick up the ball and say, across the state, across all of these agencies, we have to have a common set of policies about public mental health in order to be successful. So, I guess that's at the topic at the set, at the top. What I say at the top is how to think about data. Well, to me, this is the first starting point. When you think about data, you think not only about data under the control of the state mental health authority, but you think about data that tells a story about what's happening to as many individuals as you can find out about who are regarded as seriously mentally ill in your state, which means that you need to know what's happening in data systems that go well beyond your own you needed to know about. Medicaid data, health data, housing data, etc. Okay. Excellent. Where can you look for data? And here are some prominent examples. Obviously, you've got your own client information systems. Generally, or often, they're separate community and hospital information systems. The Medicaid Management Information System is obviously a huge source of data. Some states do take off the chunk of Medicaid data that includes all mental health in order to be able to analyze it, understand what's going on. Most of your licensed providers exist because they're getting revenue from Medicaid. Another source that people don't necessarily know about are general hospital discharge abstracts. When you look at Medicaid data, you're only looking at the group of people who are eligible for the state Medicaid program. But in fact, there are other people who go through your local community hospitals. For example, people who are insured by Medicare, or people who are free care, or people who are private insurance. So if you want to understand what's going on in your local community hospital system, you need to find a source of data with that information. And God help us, it exists. Chuck?
Yeah, I've heard of state hospital associations sometimes having a lot of that together.
Yeah, it varies. The federal government gives money to state health departments to maintain these hospital discharge abstracts. Oh. Some state health authorities use their own staff to maintain the system. Sometimes they'll contract out to somebody else, and sometimes when they contract out, it will be to the State Hospital Association. That's one of the things we learned in Minnesota, because I was talking to folks and saying, well, you need to understand what's going on in those inpatient programs as well as your own. And lo and behold, the Minnesota Hospital Association had a contract with the State Department of Human Services, under which the Adult Mental Health Authority was lodged. And so there was a reasonable way to ask for that information. Wow. They still don't have it, but there is a path.
Yeah. I've heard of states working together with the hospital association, but that was very informative. I don't know what level of data, like you get diagnosis in there, would you be able to tell whether a person had a serious mental illness?
Well, yes and no. You've probably got, I can't remember, 15 to 20 data elements in a discharge abstract. It includes diagnosis, primary and secondary diagnosis. So sometimes you can tell if someone has a secondary substance abuse diagnosis, often helpful. It has demographic information, date of birth, gender. I can't remember whether it has race, ethnicity or not. And then it may vary by state. It has the date of admission, the date of discharge. So there's a variety of data elements that you would want to have. And when I worked for the state of New York, we actually got a full set of hospital discharge abstracts for everybody with a mental health diagnosis in the state who was hospitalized in the year. And we were using it for a purpose that I'm really not going to talk about now, but for trying to create a need methodology for inpatient care. That's like another story that I won't get diverted into. But it tells you stuff that you need to know, and I'll come back to what it is you need to know in a minute. One of the things we learned, which I didn't know, was that there are a fair number of people who are admitted with a psychiatric diagnosis to hospitals without an inpatient psychiatric unit. I'm sure that's pretty common, particularly in rural states. And New York actually is a rural state, believe it or not. Most of the geography of New York State is rural. And so you had people being admitted to community hospitals. Kristen mentioned this briefly before. My colleague John Pandiani in Vermont, who recently retired, figured out how to match information about Section 8 program participants with information in his state client information system. He used a technique that he developed with Steve Banks called probabilistic matching, but they could figure out, using that approach, how many people were in that HUD subsidized program. In Section 8, it's obviously one of probably 15 HUD programs. I don't know how many there are, but it's one of the biggest programs. And so it's a pretty significant program. So that was a useful piece of information. And it's one of the things that we suggested that states do under the Olmstead Project is figure out how to get access to that data. You may not be able to get access to all 15 HUD programs, but the state itself often holds a large piece of it. What they don't have, you probably have to go to public housing authorities. You know, if you've got a big state like Minnesota, you don't want to go to every public housing authority, but if you go to the one that covers Minneapolis, St. Paul, you just got probably 50% at least of the people who are receiving housing vouchers or whatever under these programs. So there are strategies to learn about that, and I think that's something useful that people should do. And all these other state agencies have varying amounts of data. For example, if you're interested in employment, you know where you can get employment data to find out whether people who are in your system are employed and how much they're making? There's a state unemployment insurance agency. And for you and me and everybody else, our employers report monthly on the fact that we're employed there and how much money we made and obviously a few other things. So there's data there that you can match if you want to know whether people get employed or not. And you can find out, because we're always curious about this, what happens after people leave our system? Well, you know when they left your system, they stay in that employment system, so you can figure out whether there's a benefit that goes beyond the time they spend in your system. So there are lots of things to do that can be done with data that's available in other state agencies. And John Pandiani made almost a career of this in Vermont. Serially went from one state agency to another, figuring out how to get this information, how to do the match, how to learn what was happening to people who are served in their community mental health centers. Vermont is a CMHC state. They have 10 catchment areas, 10 CMHCs, which are the primary provider of community services there. No other states are configured different. But there's lots of things that you can do, lots of questions you can answer if you begin to explore what is at least theoretically available elsewhere. Nathan?
Yeah, so two other, I guess, systems that I wonder about too that you don't mention up here, and your any experience you've had trying to access data from them would be military/VA and tribal providers. And, you know, I know that very separate from state government, so there's definitely probably some barriers there, but I'm wondering, I mean, those are definitely people who also reside in the state.
At one point when I worked in New York and I was doing this inpatient need methodology, I said, geez, I'm leaving out the VA. Exactly the question that you're raising. And I kind of talked a little bit to Rob Rosenheck, who is a very well-known psychiatrist, mental health researcher, who was at Yale in the New Haven VA, and who had access to all the information about VA hospitalizations in the country, which are then resided on a server somewhere in Texas. But for whatever reason, I didn't have the time to follow up. But certainly that data exists. Now, it is damn hard to get data out of the VA, because we worked on it in another context. We were doing a national evaluation of the Sampson Jail Diversion Priority to Veterans program. And actually that's still going on at AHP since I left. And we started to work with people around trying to match data that we had for each of the grantees with data they had. And we butted our heads against the wall. It wasn't easy. So I don't have a solution to that, but I know the data is there, and in theory, there ought to be a path to get to it. With tribal organizations, I have no experience. And, you know, they vary in size. I know in Oklahoma, the Cherokee Nation has a huge system of service, or relatively large. Other tribes don't really have those kinds of resources. They get it from gambling primarily, I believe. But if somebody wanted to do that, in principle, it ought to be possible. On the other hand, even before you get to the tribes and the VA, there's lots of other things to look at, unless there's some good reason why you want to put that first on your list. Any other questions or suggestions about this? How many people have been using this kind of data?
Colorado had a project a couple of years ago, and actually they've approached this a couple of times when they tried to look across different systems, and the goal or what the state was trying to do was to get these different agencies to keep track of the behavioral health services that they funded, and that never made it up, but they were able to get data in a short period of time on clients from each. Well, Charlie, yeah,
Yep.
initiated that project. You could say more about it than me, and we could actually do a matching algorithm and say how many people are in each cell, you know, 8 state agencies against 8 state agencies. Now, how that was used is another question, and whether anyone found that, how they found it useful. We used it in the needs assessment, but you're talking about something a little beyond maybe that.
Yeah, I mean, you're using it potentially for outcome data.
Yeah,
Some
I think
cases.
that was a good idea.
Yeah. The National Research Institute, in addition to its expenditure and revenue study for states, has also had an other state agency expenditure. I couldn't remember the name over lunch, but it just came to prison. Study in which they asked states to get information about expenditures on mental health services.
Yeah.
So, for example, they asked that of corrections, they asked it of child welfare and other agencies. I don't know how many people have participated in it, but it does give some idea of the capacity elsewhere.
Yeah, it did in 2006, but there's talk about starting it over.
Yeah, they did 2 waves. I don't remember the years. I'm sure you're right about the last one.
407.
Yeah, and SAMHSA is always talking about funding it again, which would be great.
I do want to kind of put out, and you had mentioned this, John, I think one of the issues is how do you build this into the ongoing relationships, not just a project-based relationship to collect and share information, but how is this part of the infrastructure of a brand new state and or county structured healthcare system with research and database?
Well, it goes back to this last point here. If you see yourself as a convener of public mental health policy in the state, and you convene the other state authorities, then you create a platform upon which you can build relationships that will allow you access to data. Oklahoma, among other states, had these large transformation grants. They convened a governor's transformation group in which they included all these other state agencies. And it did help in getting access. Again, nothing is easy. You always have to work on it. And in the end, in part, it comes down to one-on-one relationships. But it is doable as long as you have the staff and invest the time to getting it done.
Can I go on with that, or are you kind of in a hurry?
No, that's okay.
I think, you were very successful in getting people together very quickly to provide, and they provided, it amazed me how quickly they were able to provide files for us.
It went away just as quickly as the project went away. And I say that not out of any type of criticism. I think that, yeah, convening, you can be tremendously successful. I think it also goes back to the role of the relationship, power the state mental health authority has within states to actually convene. I think one of the biggest challenges going back on what we did 5 years ago was we had the largest state agency saying, hell no, I don't want to spend the time on this. That's Medicaid. And so that was one of the biggest challenges. My point is, particularly when we think about a new kind of transformed healthcare system, how is this not just convening for a particular project, beginning and end? How is this actually part of the fabric of the healthcare environment for the state? So it's not just to convene, but this is a requirement. This is a sustaining entity and shared value that is, it's not just based on relationships as much as that plays out, but it's actually that shared core.
Once you've got those relationships, if you institutionalize something, it's not hard to do a data mart that would capture those data every year
Sure.
and generate.
Yeah.
So that part's not, so you're, okay. So it's really, you're saying that people do not, there's not enough agreement about the need to.
Agreement and incentive, this shared understanding and principle, and
Yeah.
I think what's being presented is absolutely right.
Yeah.
It's how do you move from something that's project-based to institutional.
Yeah, this piecemeal stuff is informative.
Again, this is another answer, not necessarily a great answer, but when I think about people who have been pretty successful at this, I mentioned John Pandiani in Vermont, Steve Davis before he retired, but the leadership continues under Mark Reynolds in Oklahoma. These are long-term relationships that people have with the other agencies. So even if your state mental health director isn't stable, which unfortunately is too often the case, a level or two down, there can be relationships that are stable and that can provide a foundation for making this work.
But you have to institutionalize that because even those people change.
Yeah.
Okay, that's great.
Yeah. Other comments? Okay, I'm going to come back to Minnesota, but the lessons go beyond Minnesota. Again, under the rubric of how do you think about data? The first question that I suggested that people in Minnesota want to ask is about access. You've got these different important services, whether it's inpatient care, state or local, whether it's their intensive residential treatment programs, whether it's ACT teams, whether it's housing. You want to know whether it's available, not just in kind of one big number for the state. That's kind of curious, but the fact is it doesn't do you a whole lot of good for planning or thinking about what you want to do next. You really need to know comparatively for different geographic areas in the state. Now, every state has different ways of carving up their geography. In Minnesota, not unlike a lot of Midwestern and Western states, there are hundreds, not hundreds, but 60, 70 counties. And a lot of those counties are very rural with a tiny population. So if you start looking at per capita for those counties, you're going to get a lot of instability in the data. It doesn't really help. What you really want to do is combine counties in situations like that into regions that you can use for planning purposes that also make sense from a service point of view.
Yeah, it's interesting that you, definitely about the geographic, that you did per capita admissions, and my mind wanted to go to individuals and days or something like that, but really all you can get is admissions, isn't it? You can't duplicate across.
Again, that's an example. Per capita admissions is relatively easy to get. Now, of course, it's easiest to get in the Medicaid data if you have access to it, but when you're looking at something like inpatient care, the Medicaid data is only part of what's going on, and that's where I would say, oh, you got to get that discharge hospital abstract data in order to see whether those local inpatient units are backing up, in order to see, at least for point of view of access, per capita admission rates. Now you could do per capita bed rates, you could do other things too. This is just one example. And it depends on what makes sense to you in the context in which you're working.
So I'm going to just go one more step deeper with it. So if you had hospital association data, is that duplicative with Medicaid data?
Yes, because all the Medicaid admissions will be in
Would be included.
the hospital discharge abstracts.
Yeah,
So you
just
can't
be careful about your
pile one on top of the
Yeah.
other. You just use the hospital discharge abstracts. And if it's available, it's a pretty simple system to use. It's easier to get data out of that for inpatient care than Medicaid, which can be sloppy for a variety of reasons. So access is an important question to answer, and yet it's often not asked. When I collaborated with Oklahoma on their transformation grants, we literally did maps showing differences in access for different kinds of
Nice.
services across the state. Pretty easy to use that mapping software, and some pretty big differences will jump out at you when you look at it. Maybe that's useful in going to the governor or the state legislature and saying, hey, we need to fill in some holes here. People who need access to whatever service it is aren't getting it. And again, it's not like saying you know exactly what the per capita admissions ought to be for any particular program. If you do, that's great, and you can put that in as a benchmark, but mostly we don't. So the next best thing is to look at a comparison of per capita admissions from one place to another and assume that the places that are high are probably reasonably utilizing the resources they had. You don't want to rip resources out of there, put them someplace else. Okay, next issue is lengths of stay. When you start looking at length of stay data, they can be all over the lot, whether it's inpatient or step down, rehab treatment units, whatever it is. What difference does it make? Well, if one unit with the same number of beds serves twice as many people in a year as another unit, similarly situated, providing the same program, then that capacity in the first unit is at least being more efficiently used. I won't argue it's being more effectively used, but I don't know, although it's something you could look into. But length of stay is very important in understanding the utilization of services. A very different issue than access. So once somebody get in, is there a tendency for them to stay too long? Does the unit get comfortable with them, or do they have difficulty placing them to whatever the next opportunity ought to be? So if you're trying to figure out what's going right, what's going wrong in your system, length of stay is another way to look at it. And as I said, you can look at average length of stay, you can look at percentage of discharges after more than 30 days. If you're thinking about inpatient units for other kinds of programs, you'd probably choose a longer period. Up to you, but do something. Don't ignore the problem, because I promise you, it's there. This can be related, percent capacity and use. Again, I mentioned a couple of times the intensive residential treatment programs in Minnesota. One of the things that their data group has produced so far is an estimate of capacity and use for those programs. I don't remember how many programs there are, but something like 15 to 20. Some of them are operating at 90% in the last year, 2012. But there were one or two that were at 40%, and others that ranged in between. 90% is terrific, I'll take that anytime. But if you're somewhere in between 40 and 90, it suggests underutilized capacity. And if I'm the state mental health program director, I will be damned if I will add capacity to that type of program until I've figured out how to get the capacity that exists into use. So if you want to understand why things aren't moving in your system, capacity use is another thing to look at. It'll be related to length of stay. The two things are going to be correlated. But again, you want to look at those kinds of issues to understand where your system may be getting blocked up. And it's not just inpatient or residential, but it can be other things. It can be outpatient programs, it can be emergency programs. All of those are amenable to the same kind of analysis, to raising the same kind of questions. A fourth way that I have here is really a different way of looking at the data. And again, a number of you may have heard about this. Another approach is to try to identify those people who are repeat users of acute services, particularly whether that's emergency services or inpatient services. You can go into the Medicaid data, and one of the things you'll find typically is that something like 10% of the individuals account for 50% of your costs. Well, looking at that is not just a cost-saving issue. If people are cycling through your acute services, your emergency and inpatient services multiple times a year, that's not doing them any good either. That's not what you want to happen. And so some states and some localities have developed programs, and they identify people and they try to enroll them in assertive community or intensive case management programs to have people work directly with them one-on-one to figure out what it is they need access to. And it could be housing, it could be outpatient services, it could be any number of things that will prevent them from having to recycle through the year through these acute services. So that's another very important use of data. And these are the people who are backing up also in state institutions or other inpatient care. So again, if you're trying to understand what's stuck, why your system is stuck, these are the kinds of questions that you need to be answering, and that's what I've suggested to the people in Minnesota they do, and they have lots of data to be able to look at these things. It's not like the data isn't there. No, it may not be perfect data, but it's close enough for government work. And it's sad that people aren't looking at it. So, let's see. Okay, now I know Chuck's talking tomorrow about setting up work on a performance management system in Alaska. And so I'm interested to hear what he has to say about this. This comes out of two things. One, out of my own knowledge of what's happened with state performance management systems in the 70s and 80s. There were a number of very good efforts to set up systems in Pennsylvania. It was the longest and most successful. In New Jersey, in California, in Vermont, and elsewhere. What happened to all of those systems? And they were really interesting if you look back at the history and look back at the detail. People were talking about what are the 10 most important things to know. Well, the 10 most or the 35 most important were in those systems. But what happened is states didn't really use them. In Pennsylvania, which is the longest standing system, they actually did use it. It was a county-based system, and the counties that were the highest performers got more money from new appropriations out of the state budget for their programs in the next year. And the amount of new money they got was correlated with where they stood on this performance management system. But it died around 1983 when there was turnover at the level of the commissioner, and the new commissioner looked at the system and said, that really doesn't fit my values. Let's pull the plug on it and replace it. Well, 2 years later, she was gone, but nobody had replaced that system. And it was a system that had built into it procedures for changing the indicators. It wasn't like you were stuck. In the 7 or 8 years that they ran that system, there were changes over that period of time. Do you have a question? Oh, no? Okay. Just kind of keeping your hand alive.
Sorry.
People want to stop again. Stop me, ask questions, do my best to answer. So I'm not sure performance management systems are such a good idea. It kind of makes the assumption that you know what you're doing. And most recently I confronted this in Minnesota. I said, well, the director wanted a flow model. What are we going to do for a flow model? And the answer I came up with was, using the kinds of data that I described before, we could set up a system of expectations for annual admissions for every program in the state. And then we could report on whether those expectations were met or not met. First problem is, how do you decide the expectation? If you have people who are doing quite well, they're not going to have a problem, so you're not going to have a political problem. But for people who you're pushing to do many more admissions annually than they're now doing, that could be a political problem. So you probably have to not make it impossible for those people, but move them in the direction where you want them to be in the next year, and maybe change it a little bit the year after that, and so on and so forth. Because if people are getting admitted at the rate that you decide, that means you're getting flow through your system. And that's what they wanted, flow through their system. And if you see a difference between what you expect and what you observe, then you got to do something about it. Which leads me to my next section. Rather than having a performance management system, I would call it a signal detection system. And while I was born while World War II was still going on, it was the tail end of the war, so I really don't know a lot about this at that time. But what I understand is that that's when radar started to be developed. And we put these radar installations, on the east and west coast of the United States, so we could see if there were enemy planes or whatever coming in. And an operator would sit at a screen that looked something like this, and there would be blips, and the operator had to figure out whether that was a dangerous situation or whether it was just a dark cloud or something else. And if the operator had reason to believe, and I don't know how they decided this, that this was potentially dangerous, they would send a note to the Air Force, or maybe they were part of the Air Force, and the Air Force would send up a fighter jet to look at that object and decide whether it was a problem or not. Obviously, you didn't want to do that for every object, so someone had to, because it's very costly, but someone had to exercise some judgment. Actually, I was reading a book review, and I apologize for not being able to either think of the name of the book or the author, but it was fairly recent. And it was about the Cold War and the development of all of our nuclear arms. And there's one funny story about a wrench being dropped in a silo, I think in South Dakota.
Of course.
Right?
Australians there.
That could have triggered the rocket, which was armed inside the silo. Fortunately, it didn't, but this book is kind of, I won't say replete, but has a number of stories like this. And one of the interesting ones was about this kind of a system. Apparently, the Air Force had developed a very advanced form of this system where they could definitely identify dangerous missiles now, because we're in the early 60s, that might be coming from the Soviet Union. And lo and behold, someone's sitting in a screen, and something is identified by this expert system that looks like an ICBM coming into the east coast of the United States. And they got 20 or 30 seconds to decide whether to send missiles back toward the Soviet Union in retaliation. Well, as they were working this problem, somebody realized that Nikita Khrushchev, then the leader of the Soviet Union, was actually in New York City at the United Nations. So they figured, probably not. And in the days that followed, in investigation of this expert system, it turns out that the signal that they saw was, I believe, the moon rising over Iceland. Now, there's a lesson in this for all of us, and that is, contrary to what we think about performance management system, where we know whether a provider or an organization is or is not doing the job the way they're supposed to do, instead we're saying, there's a signal here. What do? We got to send a fighter jet up to look at it, or the moral equivalent in our current day. And we don't often do this. And again, you can't look at every signal. You've got to choose the ones that are most important, but it is probably going to be valuable to go out there and look. So if you've got a system of expectations around admissions for a program, and the admissions that you're seeing are wildly lower than you would expect, so you understand you're not getting movement that you need in the system, then why not send a couple of people to the agency and say, gee, the data looks like this. Is this accurate? Is this what's going on? Why are you having this problem? And so on and so forth. And then maybe you intervene with technical assistance. Since, as I say, these days state mental health authorities are unlikely to reward or punish with money or other incentives or disincentives, the answer is probably to provide technical assistance. You can do something different in your own state. I'm just telling you what I've seen from my experience. So I think this is an important idea, and I think it would be useful for states to use the data that they have regarding access, lengths of stay, capacity and use, to set up admissions expectations and potentially to use that as a way of modeling movement through the system so that you see where things are getting stuck, you find outliers, and you do some investigation to determine what the problem is to try and figure out how best to intervene. You know, maybe you take an agency that's doing a really good job and give them a little bit of money to go provide TA to the agency that's not doing so well. It doesn't have to come from somebody on the staff of the State Mental Health Authority. You got lots of options. So, here's an example of something that way of displaying data, signal detection. This data comes from Western Massachusetts, where Nathan mentioned I serve as a voluntary president of a citizens area board. And I sat in on some meetings with providers where they presented data to the providers about how they were doing on various indicators. And frankly, the way they were presenting looked pretty obscure. So I found a student who was willing to work with me, wonderful person, and we developed, 10, 15 pages that look something like this as a different way of displaying their data. So here's a case where you're looking at people experiencing inpatient or crisis events in a community rehab program. In Massachusetts, they took the step about 5 years ago of creating a kind of partial capitation program in which they wrap their housing, case coordination, other rehab dollars all together, and they pay people or pay agencies to work with these individuals, and they do the best they can with the money they have. And theoretically, if things work well, you don't prevent every inpatient or crisis event, but you should reduce the number. Well, here are 10 agencies, US, I can't remember now, compared on this measure. And if you look at the green bar, green's good, that's go. You can see at the top, well, maybe you can't see, but I'll tell you, about 70% of the people in that program over a year do not experience any crisis or inpatient events. And then you've got, another 12% or so who experience 1 or 2 events, and then about the same proportion that experience 3 or more events. That's in red because 3 or more events doesn't look so good. So that's why we highlight it that way. And as you go down the bar chart, you can see that when you get to agency C at the bottom, the proportion of clients with 3 or 4 events drops to less than 5%. So, the top agency may have a problem. What can we do? Let's talk to them. Let's figure out what it is. Let's let them know that we're tracking this and figure out what we can do to solve it. Now, in the interest of time, I won't go over the next figure, although you have it. it's kind of a similar figure, and as I said, there were probably at least a dozen more. And student and I, T.C. Kent, presented these to all of the agencies. Okay. So this is kind of wrapping up, I guess, at least of this part. Is that right here? Not in my hand. Well, anyway, this is redundant with what I've said already, so I'm not going to go over it. You want to look at these kinds of issues with a variety of things. Yeah, somehow these slides are out of order. Yeah, I've kind of said all of this, so I'm not going to go back over it. Okay, last thing to say is I focused on certain kinds of questions, but they're not all the questions that you would necessarily want to ask. There are other kinds of questions that you would ask that require different but similar kinds of data and that you can use to take the same kind of an approach. And here's a sample list of those.
So it strikes me these are getting to access and flow through the system.
Yes.
And process kinds of things, but not outcome kinds of things.
They're not outcome kinds of things. And I don't have much in the way of outcome because that wasn't what the state of Minnesota was asking me to focus on. But, you know, I've implied by discussion about how you use other agency data, you can find out about the likelihood that people get into the criminal justice program. You can find out on the positive side whether people are getting jobs and how much they're paid. So there are a number of things you can do, all with secondary analysis of available data. And I'm not saying you should stick to secondary analysis. You know, somebody mentioned earlier going out and talking to people, doing surveys to see what individuals think about the services they're receiving, how their lives are going along. That's also important to do. But I'm just not focusing on that on this presentation. Okay. So, data can do a variety of things for you, which I've been talking about. Most important, they can identify inefficient uses of resources. If you look at per capita admissions or something else per capita as a measure of access, that's one way of trying to justify new investments. Also, if you see certain flow problems, you might think that a new investment, you know, whether it's justified by an access measure or not, would be appropriate. And so you use the data in order to try to justify that to the governor or the state legislature or whoever. I guess the last point is, if you are going to go to the trouble of trying to identify problems, then even before you go looking at them, you're going to know anecdotally what you're likely to find. So you should have in the back of your mind a plan for what you're going to do to address them. You know, don't say, oh, we'll wait and see what the data says. Well, the data is going to show problems. I've never seen data like this that didn't show some kind of problem. So you are going looking for trouble, anticipate it, and think about what you want to do when you see it in advance so that it doesn't come as a big surprise. Okay. You know, we kind of talked about this a little bit before. Chuck raised it, Charlie raised it. Data alone won't solve problems. One of the things about public mental health is it's just becoming increasingly complex. You know, if you go back to the 1950s, the state budget for the State Mental Health Authority was the money appropriated for your state hospital. And then you started to get some state-operated community programs, some state contracts, and so there were new appropriations and a new way of financing the system. Now, where you signed all these contracts with individual providers to do this or do that. And then, as someone was saying before, you get to the mid-60s and along comes Medicaid and Medicare. Did they take away the other methods of financing? No, they did not. Medicaid and Medicare get layered on, along with actually SSI and SSDI, which existed before. Then in some states you have county governments to deal with. I don't remember what the number is now. It's probably 20, 22, 23 states in which the state block grants or otherwise gives money to county governments, which may operate programs or provide contracts to providers. So that adds another layer of political and financing complexity to the system. Helps sometimes if there are multi-county community mental health centers, which there are in a number of states with lots of small counties. Tribal governments were mentioned by Nathan. You also have healthcare plans. That's kind of the newest innovation, right? Lots of states have taken their Medicaid program, and some of it's still in fee-for-service. That didn't go away, but they layered on managed care plans. You know, that's particularly true in Minnesota. So you got these plans that enroll people. Minnesota has a particular set of problems, as I understood it from one provider. People can change plans monthly. What she said is every month on the first week, towards the end of the first week, they look to see who's still enrolled in the plan if you're, that provider bills for that person. And if they change plans, then you as the provider have to work with the new insurer, the new managed care organization, to get them to agree to the plan of care so you can bill them. And again, all this is just layered on the other methods of financing that we use. Another thing that is true in Minnesota as well as elsewhere is that they will rely, particularly for inpatient care, on hospitals that are outside the state boundaries. If you're in southwestern Minnesota, closest big city is Sioux Falls. That's where you go, right? You folks are providing inpatient care to people in Minnesota, in that sort of southwestern corner of the state. That adds another layer of complexity to the financing of the system. And now we're going to have accountable care systems under the Affordable Care Act. And I got to tell you, I don't really quite understand what this is going to do, but I'm pretty sure that whatever it is, it's going to be layered on top of all the financing mechanisms that we already have. So that really does raise obstacles, both to making changes in the system, to controlling it from the point of view of the state mental health authority. And I said, particularly with the last one, I don't know what you do. But maybe that'll be clear in a year or two after the Accountable Care Act, or the Affordable Care Act, whatever ACA is, I lost track, sorry, shakes out. But you got to track this stuff because that's where your people are. Okay, let me go on and go to this last piece about housing. I have some personal interest in housing because I was involved in a national study of supported housing conducted by SAMHSA now probably 15 years ago. And I'll talk a little bit about that. One of the reasons that SAMHSA embarked on that study was to find out if, in fact, it's true that people who are in supported housing do as well as people who kind of move through different levels of housing supervision through a continuum of care. And when you talk to people, some people say, yeah, we're all supported housing. Some people say, yeah, but we're really a continuum of care system. So the continuum of care holds on, and not just by its fingernails. It's really around. And as long as the philosophy exists that people, for example, can't go from the state hospital in Anoka in Minnesota directly to supported housing, you got a significant barrier to placement. As long as people think about the need for a step-down unit that is very restrictive, you're going to have problems finding housing. Now, it's not necessarily easy when you do it as supported housing, but I think you have a better shot at it. There are all kinds of barriers to development of new housing. I don't want to say it's easy. Depends on the state and particularly the locality and what the rental market is like. But there are lots of areas actually where there are places available to rent, or in some cases even to buy. And so you can't just go around complaining rents are too high. Lots of places they're not too high. And the problem often is that state mental health authorities aren't real estate developers. No big surprise there, so they're not going to do that job very well. Actually, the same is true for most community mental health providers. They're not real estate providers. So there needs to be some kind of partnership to get over that. And there are places, and particularly in Colorado, I think of the Colorado Coalition for the Homeless. It's not labeled as a mental health program, but a huge proportion of the people they serve are individuals with serious mental illness and a history of homelessness, as well as hospitalization and other problems. CCH developed its own real estate department, and they figured out how to buy properties and then, using HUD financing, develop them and rent them out to people who are homeless. And there are a few other places in the country where there have been efforts. When I think of one that I'm just familiar with, there's the VinFem Corporation in Boston. Actually, they operate outside of Boston. It's a community mental health provider, but they created a sister agency to do housing development, and that's what they focused on. And so VinFem suddenly had all these HUD-supported housing units they could use for their clients. So, okay. Actually, but this is not in the order. Maybe I should just look at this instead of my piece of paper. My apologies. Yeah, I'm sorry. I went over before all of these different changes in financing and organization of affecting mental health care. And as I said earlier, you're not going to be able to eliminate the mess. It is what it is. What you need to do, as we've talked about, is build informal, formal communication channels, be a convener, work with people, understand what's going on, try to clarify policy and roles in a formal way if you can. Another thing is you can't just do this at the state level. A lot of the authority exists at a local level. When you're trying to get somebody placed out of a local inpatient unit, or even they're trying to get placed from the state inpatient unit into a local area, if there's a county mental health authority, they may have the authority to say yes or no. You've got your local providers. So at a regional level, there also needs to be this kind of convening. Regional collaborations need to be formed in order to talk about how to deal with these issues. The value of the data is that once this kind of organization takes place, there's a place to share it. You can't just share it at the state level. You've got to have these regional collaborations where people need to work together in order to make those flows in the system happen. And you need to share the data with them and say, look, it looks like you got some problems. You sit down together and figure out what you're going to do to solve it. Because the state mental health authority has limited resources. Even in a small state, it's not necessarily politically easy to reach down and say, you do this, you do that, you do the other thing. You really need to get collaborations working. And I'm not saying it's easy, but I really think that's the only path to solving some of these kinds of problems. Okay, data cannot create housing. Lack of placements is a problem. Again, I went over issues related to the continuum of care. What people don't realize is there actually have been a small number of studies that have addressed this question of whether or not people coming out of state hospitals or out of homelessness can go directly into their own place. Turns out they can. So this gives a little bit of description of a study that I was involved in. This is one site, the Massachusetts site, so 6 that were in the study. I also was in charge of a New York site, but I'm going to focus on Massachusetts. Again, part of the study was that people have better outcomes if they go into supported housing versus some more restrictive alternative along the continuum of care. And the bottom line answer is, well, they didn't do better in supported housing, but more importantly, they didn't do worse. People tend to assume that if you take someone out of a state hospital and put them in their own apartment, they're going to be back in that state hospital in 30 days. Not true. They're no more likely to go back to a state hospital in 30 days if they go into supported housing than if they went into a group home. And the same is true if they're homeless. So I can't tell you that supported housing has proved itself to be better, but it's definitely not worse. And I think that's the most important assumption that many people in the public mental health world carry. That you have to have a step down, you have to have a continuum of care. If they go from homelessness or state hospital or some other restrictive alternative into their own apartment, they're not going to make it. Yes?
Did these studies take into account that generally in a state hospital setting you send people who are better or more stable to independent housing, like yes. So you took into account the severity of the case and how people generally place them?
Yes and no.
Okay.
I'll come to your response in a minute. I'll talk about Massachusetts as an example. At the time that we were doing this study, there were housing placement committees convened in relatively small areas of the state. The state was divided into 40 geographic areas. The housing placement committee would be convened, depending on the size of the area, once a month or once a quarter, or sometimes even once a week. And everybody would sit down, and the people who were representing an individual who needed a spot were there and saying, I've got so-and-so ready to leave this or that, and what's available. And the residential providers would sit there and say, okay, here's what we have. Resources were really in short supply. So what tends to happen is that whatever slot is open is what the person is assigned to. I mean, occasionally there might be objections raised if there was a history of dangerousness or something. But remember, the state was the convener of these meetings, and the state was very interested in seeing people placed. So the kinds of objections that you might imagine could be overridden in these meetings. And so to the extent there was risk, real or imagined, it was really on the housing providers to accept it. The other piece of this I will say is that the coordinating center that was in charge of this study that worked with the 6 sites at first wanted to do random assignment of people to one housing type versus another in each of the study types. And we ended up agreeing as a group that this didn't make sense because the most important principle of supported housing, or one of the most important principles, is that an individual make a choice. You can't randomly assign people to houses or housing types. Now, I'm not saying, as I described the Massachusetts system, there was a lot of choice. You know, people were interviewed about what they wanted, and there would be some effort in this meeting, but since housing was in short supply, frankly, it was virtually random assignment. Yeah.
I actually had a comment rather than a question about things that are counterintuitive about trying to rig the outcomes that way, where you cherry pick the people that are most likely to succeed. It's actually from a program that when Carl Bremner was in Multnomah County, it was one of the first service brokerage run by peers. That population selected from some of the county mental health programs, both for its employees as well as the people that were recipients of the brokerage dollars. It was about $3,000 a year attached to each person. They got to choose basically areas that they wanted to spend their resources on, including services. The clinics that offered up the names actually tried to say, you know, you want to pick this person here, or we'll give you a list of people we think are likely to succeed. And what happened was they actually discarded those lists and just let the people who wanted to participate sign up, including people at the clinic said, hey, this isn't going to work. It actually turned out, and there is some data from the outcomes from that that's actually available, that was done by a technical assistance agency in Oregon, that those people that were most likely to not succeed according to the clinical assessment were actually most successful in the brokerage program. So there's no guarantee that the clinical prediction, those models don't seem to function as well, especially if you empower people. There's different people that respond to that much differently than the clinical model is willing to admit. So.
Yeah, 25 years ago now, there's a paper that actually Courtney Harding pointed me to by a psychologist named Pat Cohn, in which she talked about a phenomena she called the clinician's illusion. You're familiar with that? It's a really interesting idea. And basically what she says is that clinicians, therapists, case managers, whoever they are, see individuals for a relatively short period of time. If they're lucky, it might be 2 years, but often it's less than that. So you may see people in a time where there isn't a lot of change. And because that's what you see, and you see it repeatedly with person after person, you come to believe that these individuals who are labeled seriously mentally ill don't change. Well, if you look at the kind of work that Courtney Harding and others have done, where you look longitudinally over 15, 20, 25, or 30 years, hey, it turns out they do change. And I think the clinician's illusion, the term that Pat Cohn uses, is one of the barriers in the system that accounts for what you were describing and other kinds of resistance that we see to moving people into supported housing. And again, supported housing isn't saying, okay, we're going to give you your own apartment and then goodbye. You're supposed to provide supports. Although sometimes those programs have received less funding than group home programs or whatever else, so they have a diminished capacity to provide those supports, but nonetheless, they can be successful. Okay, this is a little bit of data for people who are data wonks from this study. Kind of haven't provided any data. I mentioned a little bit before. This is psychiatric inpatient utilization, days in hospital. You have 6 months before they entered the program. You have the 6 to 12 months before they entered, then 0 to 6 months before they entered, then the first 6 months they're in, the next 6 months, and the third 6 months. Pretty dramatic. They experience a lot of inpatient hospitalization, particularly in people who are likely to be admitted into these housing programs. That's why they're candidates in part, as you were suggesting. But you see a dramatic drop, and it's maintained. And that drop can't be explained by regression to the mean. It's a real drop. What else do you see? Days housed. As I said, a lot of these folks were homeless, or they may have been in inpatient care. So on average, they weren't housed for many days in the 6 months prior to their entering the program. But once they enter, they're housed a pretty high proportion of the days. It's not maintained quite as nicely as the reduction in inpatient care, but not bad at all. I'll take that. And by the way, this is combining the data for supported housing and in Massachusetts group home data. And the reason it's combined is because there weren't any differences. So I don't have 2 lines on each of these charts, just one. This is the outcome for people in supported housing, same outcome for people who went into homes. Days homeless, same phenomena, relatively high number, 6 months prior to entry, and then it drops. Crisis emergency use. The change isn't as dramatic, but you definitely have a reduction from the 6 to 12 months, 6 months prior to the entry into the program to the period of 18 months that they're in the program. Times victimized. People are out on the street, they're homeless. What happens? They get victimized. They get housed, victimization drops way down. So, the bottom line for housing to understand is that housing matters. The different models don't seem to make much difference, and this is not just in comparing group homes to supported housing in Massachusetts, but also all the comparisons across all 6 sites in the national study. One of the things I did learn that program diversity in housing is important. When we think about Olmsted, we think, oh, everybody has to have their own place. And most people want their own place, and they should have it. But we had a housing advisory group in New York City in an early part of our study, and we had 2 guys who lived in a small building. They each had their own apartment. There were 6 apartments, and everybody in that building had co-occurring disorders. So it's very segregated. What did they say? They said, we really like living with other people who had the same experience as we did. We support each other. It's helpful. We like living this way. On the other hand, there was a woman in this advisory group who was living on her own in an apartment somewhere in Manhattan, a large building, and she had lived in a group home before, and she said, I love living on my own in this apartment. None of my neighbors has a history of serious mental illness. We don't talk about their therapy or what's gone wrong in their lives. We talk about the weather. We talk about restaurants. We talk about other things. I love it. So there needs to be choice. I visited in Boston a shared living situation in which this was, on the surface, it looked like a group home, but it wasn't staffed. There would be an administrator there who was 9 to 5, check in with people, but people had their own separate outside case manager. In this particular place, it was all men, so they did provide them with meals there, but there was a program, similar program for women where the women cooked for themselves. A little bit of a gender difference, apparently. These people were there on a transitional basis, and it worked for them. One guy I talked to had serious health problems, and he wasn't ready to go back to his own apartment right then. He felt insecure, and so this was a good place for him. And other people who were there had similar reasons. It wasn't that they were going to stay there forever, but there really needs to be diversity, not a continuum of care, but diversity. I met a woman outside of Boston who lived in her own apartment. She missed being in a group home. She missed the camaraderie. camaraderie, and the relationships with other people. Nobody else in the room said that. They were all happy living in their own apartment. But there are people who demonstrate that it all doesn't need to be and shouldn't be the same. Okay. You need to have subsidies to make housing affordable. You need to have services to help people find and maintain their housing, although it should be flexible. Some people need more than others, and some of those services could drop away over time. There needs to be a stock of decent housing, which is really a problem in certain urban areas. I mentioned this earlier. You really need to have a reasonable resources allocated to these components in order to make it work. The question that people should ask program managers is not, is this person appropriate or ready to live in their own apartment, which is a continuum of care question, but what does this person need, and you obviously are asking the person, in order to live successfully on their own. And we had, as I mentioned, our local advisory committees that included recipients or consumers who were great. I learned so much from those people. But we also had a national consumer council that was part of this study. And I was struck by this young woman from New York City, Lucy Kim, who said, well, the basic findings are that there are no differences in outcomes depending on the housing type. Why don't we just respect people's preferences? And it seemed like a fitting conclusion to the work that we all done. And so that's why it's here. Other questions or comments? Okay. I'm not going to go over this, but it is in your paper, some more information about the Massachusetts example, maybe about the national study. I can't remember what I did at this point. So, as I said earlier, data can't create housing, but you really need to pay attention to all existing resources. And state mental health authorities really don't know how to work the HUD system. And when I've come into communities that really understand how to access those data, it's because they have somebody outside the mental health system who's doing that work. The city of Denver, in addition to the Colorado Coalition of the Homeless, has some other providers, not quite as successful in terms of the numbers, but have used HUD program dollars successfully for a period of time under the then Mayor John Hickenlooper, now governor of Colorado. They had a program called Denver's Road Home that had the goal of eliminating homelessness in the city of Denver. And one of those people that's on the mayor's staff focusing on that is someone who really understood the ins and outs of HUD programs. He's now on the state housing staff. I mentioned diversity of housing options, addressing philosophical differences, which exist and can be a real barrier, both in development, making the right development choices and embracing people. And I mentioned partnering with housing developers. So, wrapping up, I'm sure you're glad I'm wrapping up. Just to go back over what I've tried to say. First lesson, my mind, is think broadly about the entire system. The days when people could think just about the state mental health authority dollars or people who are clients of the state mental health authority have been gone for at least 25 years. Not everybody knows that, and frankly, the way state government works, it mitigates against that proposition. But if you ask me, that's the right way to think about things. You can use data very successfully to identify problems. I promise you, if you do the kinds of analyses that I have described, you will find problems. So the hard question is, when you find them, what are you going to do about them? And I guess you want to look at the ones that you consider to be the greatest impediments to getting a flow in your system so that you can create community integration and address those first, because you've got limited resources, so you have to prioritize. Data alone won't solve problems. It's kind of redundant with what I just said, so I won't even read that. And last, data alone cannot create housing, but it can help you to understand needs and direction, although, as I kind of alluded to, there are many other steps that you need to take in order to do this successfully. So I've now kind of beaten you all down, I think, by talking for an hour and a half or close to. But nonetheless, even though I lied about this being interactive, you still have a chance. If you haven't already raised a question, to stump the chump, as they say on Car Talk. I don't know if people in the West listen to Car Talk.
Oh, yeah.
Yeah, definitely, you're right. Yeah, it's an important part of my Saturday mornings. Yeah.
In a casual conversation last night, you mentioned that the payment system was an impediment to a lot of innovations, or words to that effect, or that a lot of the things that couldn't be changed were due to the way that payment was done. Do you think that the answer to that lies either with the structure of data results, or with action at the federal level, or is it a political consideration, or is it a media event, or is it a state administrator doing something enlightened? Because we've often found that one of the few avenues of change in the system, other than trying to run up against those walls where Medicaid has clamped down and compartmentalized and siloed all of the integrated services of the policies we want to have you implement, is that the enlightened administrators are really the hope of most of the systems of care.
I think that's true. I mean, you're really talking about a policy issue. Payment systems are based on policies. They don't come out of thin air. So somebody's making assumptions about how the world works and developing policies that follow that judgment. You know, so for example, in many states, but not all, intensive case management or assertive community treatment, whatever you might think about those programs, are typically not paid for on a fee-for-service basis. They're what I would call partial capitation programs, which means if someone's enrolled in that program, the assertive community treatment program gets a certain amount of money each month for each person enrolled. The assumption is that there'll be some contact with everybody enrolled, and providers may be asked to report or certify that, but that somebody may need 20 contacts that month, and somebody else may need 3. So by having a capitated payment, the program has the flexibility to address the needs of different individuals. So that was kind of innovative thinking maybe a decade or more ago. And, you know, it created a change. And there are other kinds of changes like that that people need to make by saying, we really don't have to stick with the way we're financing programs now. We can make changes. Not that there won't be barriers, but they require someone to come up with an innovative way or idea about how you structure payment so that it doesn't get in the way of the way services are delivered, but gives programs and individuals the flexibility to reshape things so they get what they need. Another example is wraparound dollars, which have often disappeared. You know, programs might get so much per capita for each individual enrolled for wraparound. So if someone needed to get into a new apartment, they could pay first and last month's rent out of the wraparound dollars. Person doesn't need it the next month. So again, you need a flexible pool of dollars in order to be able to provide the kind of assistance that's needed. I hear less and less about wraparound dollars. I'm afraid that may be disappearing. But that's the kind of innovation that happens when people think about what makes a program work well. So that's the best answer I can give you.
Where in the system do outcomes drive the rest of the policies that you can see?
By and large, nowhere.
Other than the crunch now to have decreasing budgets with expanding clientele.
Well, I mean, that's using cost as an outcome, which really isn't an outcome. When we were doing the supported housing study, one of the things that the coordinating center wanted everybody to look at was the per capita costs across the 6 different sites. And 2 of my sites, the 2 sites I had, were relatively expensive. So frankly, I didn't like that idea. I thought it was unfair. And anyway, the whole idea that in looking at the resources these programs had, per person or per unit or whatever, represented the cost of doing business was, to my mind, silly. Why was it silly? Well, my 2 states were New York and Massachusetts. And New York and Massachusetts, if you look at any kind of funding measure, are relatively generous. Other states were not so generous, and I won't name them. So, what you really had when you look at the dollars available to each program was a measure not of the costs of running the program, but the generosity of the state. And if other states were more generous, then they would have had more money to run in other places. So costs as an outcome seem to me to be potentially very deceptive. I don't want to say there aren't situations in which it's appropriate or inappropriate to look at costs. There definitely are. But this is simply an example where it seemed to me foolish and counterproductive because the costs weren't driven by what the program was doing per se. What the program was doing was driven by the resources they had available.
So where would you say the greatest waste is in the system?
Oh, I don't know. A lot of that has to do with, kind of your philosophy about what helps people and what doesn't help people. Years ago, I read a book called 9 Highland Road, written by Michael Weinrich, who was a reporter for the New York Times. And 9 Highland Road was a group home on Long Island outside New York City. And I don't remember what the reason was, but somehow Michael Weinrich became interested in that. And he followed that program from its inception with all the neighborhood opposition and so forth until they started to admit people. And a lot of the book are anecdotes or stories. There's a chapter devoted to each of 7 or 8 people. And many of the people went into local psychiatric inpatient care, and that's described. And as I read it, could not figure out what good was doing by them being there. They would get into care. The attending psychiatrist, the first thing they would do was take them off whatever medication they were on and put them on a different medication. Now, I'm not an expert on medication, but to the best of my knowledge, that's not the best strategy. You want to know what they're on, know what it is or isn't doing, and so forth. And they're basically the only service on those inpatient units, as it was described by this reporter, seemed to be medication. So it's like, what good was that doing? So I understand that psychiatric inpatient care can be better than that, and that it does keep people safe who may be dangerous to themselves for a period of time. But I also have a sense that it's a very costly form of care that may be oversold. That's just my particular point of view. I don't necessarily have any data to back it up. What I was describing was really anecdotal descriptions that are in this book. Other people may have their own observations about where the greatest waste or inefficiencies are in the system. Some of it's embedded in programs that use significantly less than their full capacity, as I was describing before. I don't know, does anybody else want to comment on where there's waste and inefficiency in the public mental health system? Guess not. Well, I think we're getting ready to go to dinner, Chuck.
Okay, well, thank you, John.